Good morning, Justin.
Joaquin, how nice to see you. How the heck are you?
I'm doing well, thanks. I
Always a pleasure.
appreciate the kind reminder 5 days ahead of time. That was very helpful and appreciated.
Well, a big thank you to Ferris as well on that. Ferris, I appreciate your thoughtfulness, and we really I know how busy everyone is, especially Joaquin. So thank you for getting ready for this call.
Three of
Hi,
you
Justin.
were thinking about me, Ferris, Justin, and then Coulter last night about 8 says, we're presenting tomorrow. So
Well, we love you on these calls, and thank you for making the time. I know how busy you are, and hope you're holding up well with all the things. I'm at OHSU now, Joaquin. It's quite a lot going on.
how long will you be in town?
I'm here through Friday.
Oh, I leave tomorrow for DC.
Uh,
Otherwise, I'd say we should get together.
I would love that. Next time, I'll make sure I give you a notice. What are you doing in DC?
The Society for Coronary Angiography and Intervention has their national meeting. So,
Wonderful, wonderful. Well, hope that goes smoothly.
oh,
Looks
it'll
like
be
we have
fun and it'll go smoothly.
great. Well, you look well. And Ferris, are we getting ready? Let us know when you're ready. We'll stop chatting, but let us know when you're ready to start.
Yeah, we are ready to start. And today, Dr. Wonderpach is on another meeting, so I will moderate your case. Please, also you can start.
Wonderful.
Wonderful. So, good
All right.
morning, everybody. I just want to acknowledge that Coulter, despite being on a rare vacation, offered to prepare for today. And in a rare act of kindness, I said, don't worry about it, I'll take care of it. So both were unusual. So we are going to at least have one case, if not two cases, and the associated teaching points with them. I'm going to share my content here momentarily. Are you able to see it?
Not yet.
Give me a moment. How about now?
Yes, we sure
And
can.
then are you seeing
Presentation mode, not yet.
Yes, yeah, I can see the presentation now.
okay, with or without notes?
We don't see the notes, but we see the margins on the left. I don't know if you can click the bottom right icon to make it presentation mode.
I have it in presentation mode for me.
We can see your left margin. That's fine, but it's not just the slides. It actually has the table of slides, index cards to the left.
I've now been frozen, so I can't get over without disconnecting for some reason. My Dell computer has been acting up today.
Okay.
So,
Do you want to send it to myself or to Ferris and we can advance for you?
the if I could get to that screen, I would. Is it?
Okay. Can you advance the slides?
I can, I think.
Let's try. They're not advancing here. So you may have to quit the PowerPoint and then reopen.
It locked me out of that side of the screen. Give me
Take your time. And you feel free to send them to me by email and I can share them with you.
I'm going to share them with you.
Wait, now we can see your cursor. Can you try it again? Just try and put it on presentation mode.
Give me just a moment. I apologize. Give me just a moment.
Take your time.
Now what do you see?
We see your desktop.
And now?
Oh, now we see the main slide with the next slide to the right.
I'm almost there. I don't know what's going on with my computer, but
That gives us a sneak peek of your next slide.
yeah. How about now?
There, now you've got it. Perfect. Well done. Now it's gone black. Still black.
All the things I normally do are not working.
Well, we had it for a second.
I know, and I'm going to try it one more time.
Okay, that's good again.
Okay.
See it.
So good morning, everybody, and sorry about my Dell laptop. So I'm going to start by speaking about left main percutaneous coronary intervention and utilize some recent publications to focus on why intracoronary imaging is so vitally important to impact both the short and long-term outcomes of patients. And then secondarily focus on what to do with the residual disease and when. And then highlight the recent supported changes in the ACC and AHA guidelines regarding left main PCI. So left main PCI procedures have steadily increased over the recent years. In the United States, between the period of 2009 to 2016, left main procedures accounted for just over 1%. And in UK, a concomitant increase during that same period. And in Sweden, also a fourfold increase during that period. More recent data from the last 5 years is lacking, but in discussing with individuals from around the world, the market increase in structural heart procedures has led to an increasing number of complex left main PCI being performed in more and more patients. Now, if we take a look at the 4 seminal trials dating back to the Syntax trial in 2009 at the top of the screen and the pre-combat in 2011, these provided the initial data that in complex disease, that CABG was superior to PCI with first generation stents, and that PCI was non-inferior in low-risk cases through 5 years, but there were no real differences by 10 years. Using second generation stents in 2 publications, Excel and Noble, it was demonstrated that at 5 years, that PCI was non-inferior to CABG in low to intermediate risk patients. So those are people with Syntax scores of less than 32, but that the combined endpoint of death, MI, stroke, and revascularization was higher in PCI, but primarily driven by repeat revascularization. So these were the 4 trials that led to the establishment of left main PCI as an alternative to CABG. And in fact, if one looks at the left hand of the screen, ESC has class 1 recommendations that CABG remains a standard for complex left main disease with a high syntax score of greater than 32, whereas a 2A recommendation is provided to PCI as a reasonable alternative for patients with a low to intermediate syntax score, and that it provides a 2B for those patients with a 23 to 32 syntax score in favor of PCI as an alternative. The ACC and AHA provide a class 1 recommendations for PCI or CABG for left main disease that is greater than 50% angiographically, and a 2A recommendation that it's reasonable in select patients, especially if they have a low to intermediate syntax score and are at high surgical risk. So this now enables us as operators to enter into shared decision-making utilizing a heart team approach and a patient-centered approach to determine what the ideal approach to revascularization is for a given patient. As we take a look at the path to left main PCI, it begins with the patient and their shared values, and then inclusive of a heart team approach. And I think if we look here at the left hand of the screen, one has to think about the anatomy. Is it a osteal or shaft lesion, which these are typically easy to approach percutaneously, or in the middle, is it a simple left main that involves the ostium and proximal of a branch vessel? And these typically are a 1-stent strategy with a provisional approach to the side branch, or is it a complex distal left main bifurcation that has a high risk of side branch compromise and requires an upfront 2-stent strategy? What is true is, independent of which of these strategies one takes based on the anatomy, intravascular imaging is essential and is non-optional, and plaque modification is often required. And so one looks at the lesion length, diameter, the location, whether or not it's a true bifurcation, distal left main, and then importantly, the angle of the bifurcation and assessment, not simply angiographically, but with the incorporation of intravascular imaging to determine the degree of calcification, eccentricity, so that one can best understand the approach to treatment. And these are all essential things to consider when contemplating and performing left main PCI. So we start at the top. Is a left main greater than 70%? If it's not, in that 40 to 70%, intravascular ultrasound, or in distal left main, FFR can be considered. And remember the reference of 6 square millimeters or less. If either of those are met, then it's important to have a heart team discussion and then reach shared decision making with your patient. And if in fact it is osteal or mid-left shaft disease without bifurcation, these are now typically approached by either CABG or PCI. And when confronted with the alternative, most patients will choose PCI. If in fact there are factors that favor CABG and the patient is an acceptable risk, then CABG is preferred. The distal left main is more complex, and in most cases, unless there are relative or absolute contraindications, CABG should strongly be considered. Now, when we take a look at intravascular imaging for left main, I think it becomes important for one to think about the concept of 12-8-6. And when I say the concept of 12-8-6, we're talking about the cross-sectional area of the left main as ideally being 12 or greater post PCI, the LAD being greater than 8, and the left circumflex being greater than 6. And this is important because when one takes a look at the right hand of the screen, the association of the IVUS area with MACE is quite strong in the bifurcation PCI. And in fact, if in fact the left main is less than 11.8, or the LAD is less than 8, and the circumflex is less than 6, then the probability of MACE is almost 1 in 4. If you optimize the results and have full expansion, MACE is only 6.5%. So I will submit to you that performance of imaging to determine plaque modification and adequate plaque preparation and adequate stent deployment and plaque expansion is absolutely essential to providing your patient the best probability of doing well, not only in the short term, but also in the intermediate term out through 30 months. Now, interestingly, when we take a look at the IVUS image-guided stent optimization in patients undergoing complex PCI, this is a interesting analysis of the Renovate complex PCI. And they took a look and stratified people by acute coronary syndrome, which is in the red-orange, or chronic coronary disease, which is in the blue. And there was no interaction based on presentation. However, if you look at the left and you take a look at patients who were assigned to image-guided PCI versus angio, and the same for the patients with chronic coronary syndrome, the definition of patients meeting successful image-guided optimization only occurred in 1 and 2. And what this tells us is it's not just the performance of intravascular imaging that is essential. It's, as an operator, learning how to apply that imaging to adequately prep the lesion and adequately post-dilate. And if you do that, one can reduce target vessel failure by over half, from 14% to 6.5%. This is primarily driven by decrease in death and periprocedural myocardial infarction. So yet additional data that intravascular imaging to guide lesion prep and adequate stent deployment is essential. Just doing OCT or IVUS alone will disappoint you, because if you don't prep the lesion, you're still going to wind up with inadequate stent apposition and plaque expansion. Now, it becomes more important than just imaging in the left main. And if we take a look at the impact of incomplete revascularization after left main disease in the Excel trial, these are jeopardy scores, and these are the individual territories that were impacted by significant disease. And if you take a look at the right and you take a look at the composite endpoint of meaningful outcomes, death or myocardial infarction, one can see that those individuals who have residual jeopardy scores that were lower only had approximately a 15 to 20% death or MI over a 5-year period. If one left a patient incompletely revascularized, it was almost a 2-fold hazard of death or myocardial infarction. So focus on how to do the procedure and on how to completely revascularize your patient. Otherwise, poor procedure and incomplete revascularization lead to meaningful adverse outcomes of death and MI in the patients. So the recent guidelines for the first time now recommend that in patients with acute coronary syndrome undergoing coronary stent implantation in the left main or in complex lesions, that IVUS or OCT is now recommended for procedural guidance to reduce ischemic events. And this is consistent with prior data and certainly strong biases that both Damaris and I have in how important it is to image beyond the angiogram to guide the PCI. And so I'm really happy that in February of 2025, that the US guidelines now have a class 1. As you know, that means we always have to do it. It is no longer optional. And it's my hope now that we have this, that there will be an associated performance metric associated with this guideline. So I think this is a step forward for our patients because, as many of you know, in the US, there's only about a 20% utilization of intravascular imaging. And that number needs to increase, and this is a step forward. So I want to shift now to a case that illustrates some of these points on left main PCI and intravascular imaging and plaque modification. And this is a case that I had the pleasure of doing with Coulter. And this is a 75-year-old woman, former smoker, obese with a BMI of 42, hypertension, and hyperlipidemia. And she presented to a rural hospital on the Oregon coast with chest pain and found to have a non-ST segment elevation myocardial infarction. She was transferred to another hospital with a cath lab for coronary angiography. And Coulter, thank you for prepping these slides for us today. This is the angiogram. And what one can see here is a severe eccentric distal left main, post stenosis aneurysmal dilatation. And you can see heavy calcification and diffuse plaquing in the LAD and a tight OM1 in this scenario. This is the areocranial, and you can see here intermittently the critical distal left main hiding behind the circumflex, the high plaque burden, and proximal LAD disease. And importantly, we are fortunate that the operator performed a left heart catheterization, which demonstrated a markedly elevated left ventricular diastolic pressure of over 35. So we reviewed the case with our cardiac surgical team, and they determined that the patient was too high risk for coronary artery bypass graft, primarily due to her limited baseline functional capacity and the challenges of sternal healing and rehab in this patient with morbid obesity. In addition, echocardiography demonstrated that the entire anterior septum, apical anterior septum, and apex was akinetic, along with hypokinesis of the lateral wall, EF of approximately 30 to 35% without substantial valvular disease. So we started with vascular access, ultrasound guided micropuncture, angiogram, confirmation of stick below the inferior epigastric and above bifurcation. And because of the critical left main disease, thinking that this would be not an easy procedure, and the left ventricular diastolic pressure being elevated, we deemed this to be high risk left main PCI and proceeded with Impella supported PCI. So this is the Impella in place. We had two per closes, an XB guide, not yet coaxial with the left main, a balanced heavyweight wire so that we could ride the XB catheter in and out. The lesion pre-dilated with a 275 by 12 millimeter NC balloon. And I favor starting with NC balloons if there's a large enough channel in an effort to at least get partial expansion with subsequent use of IVUS to further guide what we were interested in doing regarding plaque modification and stent sizing. So this is a limited left main angio to make sure we had flow in both vessels. And we performed IVUS, which showed under expansion, and proceeded with IVL. We utilized a 4.0 by 12 millimeter balloon. And as you may recall, in a prior discussion, in presentation, we showed the importance of ideally delivering at least 60 pulses to a given lesion in order to create adequate fracturing and micropores to then adequately deploy a stent. And so we actually gave 120. We utilized it both in the proximal LAD and then in the distal left vein. And we proceeded with a 4.0 by 18 millimeter onyx frontier, and then proceeded with proximal optimization with a 4.5. And this is now IVUS in the left main, in the LAD, pulling back into the left main. You now see the stents. You see remodeling off to the right between 4 to 730. All the stents are opposed into the lesion. And now we're coming into the distal left main. And despite all of the IVL, you can see, and the NC, that there is still a component of eccentricity to the very distal shaft of the left main, but the cross-sectional area exceeded 12 square millimeters. And so we left it be, given what we have seen in adequate left main cross-sectional area, as I demonstrated to you in that one manuscript. This is the final angiographic picture. And so in left main, our approach is involve the heart team and the patient, keep it simple, provisional versus DK crush versus culotte, utilize imaging to guide the lesion preparation, stent size, and adequate stent deployment. When there are large vessels, make sure that you complete revascularization. And whether you do that at that same moment or you stage it before they discharge depends on the lesion complexities. And utilize mechanical circular support where appropriate. In this case, given the complexity and the hemodynamics, we thought Impella was the best approach. So there were a couple of other important changes in the US guidelines. The in-hospital management for patients with STEMI noted now that prasugrel or ticagrelor should be administered to reduce MACE and stent thrombosis over clopidogrel, and that in patients with STEMI managed with fibrinolytic therapy, clopidogrel remains the primary second antiplatelet therapy during the index PCI following lysis, and that one can, prior to discharge, switch them to either ticagrelor or prasugrel. But during the first several days, it should be clopidogrel. On the right-hand screen, it is now noted that there is a class 1 recommendation for patients with ACS undergoing PCI that a radial approach is preferred to a femoral approach to reduce bleeding, vascular complications, and death, which means unless there is a reason to cross over, that radial is the preferred approach. In the case I demonstrated to you, we utilize the single access through the impella, which is why we did not do the PCI through the radial approach. In the STEMI patient population, I want to finish with some comments on the multi-stars AMI that extend the findings from the complete trial. And as you know, the complete trial showed that amongst patients with STEMI, that revascularization within 4 to 6 weeks of the index PCI improved MACE over time. Multi-stars that was published in the NEJM a little over a year ago now randomized 840 STEMI patients to PCI of the infarct-related artery, followed immediately by non-culprit PCI, versus PCI of the infarct-related artery, followed by stage PCI at 19 to 45 days. And it demonstrated that immediate multi-vessel PCI was superior to stage PCI with a reduction in serious adverse events from 34% to 25%. And the primary endpoint was reduced from 16% down to 8.5%. And so I think it becomes really important to think about our ACS patients, do the index lesion, and I think now the combined data would tell us prior to discharge, doesn't always need to be done during the index procedure, that large vessels that are not complex and that are not CTOs should be revascularized before we send our patients home, as opposed to sending them home and at 4 to 6 weeks seeing whether they're having angina or scheduling them at that point. You all know the danger shock data. We reviewed them together as a group last November in Cambodia, and it demonstrated a substantial reduction of death from any cause at 6 months, from just under 60% to about 45%, at the cost of renal insufficiency, bleeding, and vascular complication. This has led to yet additional fundamental changes in the guidelines that were just published in February. If one looks at the left-hand part of the screen, we now see a class 1 recommendation that in patients with ACS, either STEMI or non-STEMI, complicated by cardiogenic shock, that emergent revascularization of the culprit vessel is indicated to improve survival, irrespective of time from symptom onset. In addition, they now go on to state that there is harm in patients with ACS complicated by shock for routine PCI of a non-infarct-related artery at the time of the primary PCI, and indicates that this should not occur because of both a higher risk of death or renal failure. And so ACS, shock, fix the culprit vessel, and defer the non-culprit vessel for another day. We don't know yet whether another day is prior to discharge or at 4 to 6 weeks, but it is very clear that we should not do it at the same time. If you look at the right hand, for the first time, there are recommendations for MCS in addition to primary PCI. And there is a class 2A indication now for selected patients with STEMI and or severe refractory shock that the use of a microaxial flow pump is reasonable to reduce death. Secondarily, there's also 2A that in patients with mechanical complications of ACS, that short-term MCS devices are reasonable for hemodynamic stabilization as a bridge to surgery. There is a class 3 no benefit for AMI and cardiogenic shock for the routine use of either an IVP or VA ECMO due to the lack of survival benefit. And so in the US, where Impella is available, that is a primary recommendation to use. However, ECMO, when there's present to both RV and LV, or in the presence of routine unloading, has not yet been tested. So I want to put those asterisks to say I still believe that there is a role for ECMO, but if you're going to use it in AMI and cardiogenic shock, as we talked about in Cambodia, it's important to unload the patient. So in conclusion, DAT for ACS, even in the United States, is now ticagrelor or prasugrel over clopidogrel. Access radial, unless it's complicated by shock and you're going to use a single access PCI via an Impella sheath. Complete revascularization with IVUS-guided PCI reduces MACE and should be the default strategy. Culprit PCI, followed by stage versus complete revascularization during the index procedure in the absence of shock, should be the approach. I don't think that it is in the patient's best interest to bring the individual back at a month unless it's really complex anatomy. STEMI, complicated by shock, an appropriate patient should be treated with Impella as opposed to ECMO with the appropriate systems of care within the CVICU. I think that ECMO with unloading has not yet been tested in a randomized trial. And I think when Impella is not available, ECMO with unloading is a reasonable alternative. Thank you.
Thank you very much. That is an excellent lecture and enlighten us more on the importance of imaging during left main PCI. And we appreciate and see the new guideline. This is the first time that I saw in the guideline that ECMO is considered class 3. Class 3. We are argued under Ministry of Public Health in Thailand for the investing on either ECMO or Impella, because now we have Impella in Thailand right now. But the problem is the policy, they ask us to purchase 2 machines, 2 Impella machines for center. What do you think about that?
Yeah, I think that the important thing is the company is asking you to buy 2 or the government?
It's too expensive to have 2 Impella machine in one center that the volume is not high. So what do you recommend?
I would have 1.
And second, when you in one of your slides, you speak about the target failure endpoint procedure MI. BDMS, we use the SKY definition for procedural MI by using troponin of 35 folds with symptoms or over 70 folds without symptoms. I would like you to comment on this procedural MI procedure.
Yeah, so I think that's a very reasonable and pragmatic approach to the definition of MI, Damras. And I think what what really surprised me is that even within a randomized clinical trial, that only half of the patients who were randomized to IVUS or OCT, and 85% was IVUS, 15% was OCT, but that only 50% of them had optimal stent outcome. And that if you looked at that, the hard endpoints were doubled compared to those that met the IVUS or OCT criteria for ideal stent implantation. And so I wanted to share that data because it really brings home to us as operators the benefit to the patient, number one. And two, Damras, as you have pointed out now over several years, the importance of learning how to interpret the data to guide the strategy of how we're going to approach that lesion. And so both of those are important. So if we think about that, and then the residual disease that we need to revascularize, it now sets a new standard in my mind for how we treat our patients. And so I was really happy to see in the February guidelines, class 1 recommendations for imaging and for complete revascularization, and that complete revascularization in the absence of shock should occur before the patient leaves a hospital. It's a big change, and I'm happy to finally see it come out as class 1.
Thank you very much, Professor Sycamore, for your great talk. I would like to ask some question about the clopidogrel. Do you routinely check for the clopidogrel pharmacogenetics in the case where we use the clopidogrel?
So in the United States, unless the patient is Asian, we don't. And so when we look at the kind of standard of care, genotyping and phenotyping responses is not occurring. And then secondarily, we know in the United States that we have a long way to go to close the gap between the use of clopidogrel and the other two agents. If we take a look at the prescribing patterns through the national data sets that you can get, it's about a 70% Plavix world in the United States for both ACS and non-ACS. We now with these guidelines think that in the ACS, we'll be eclipsing 90% shortly. Probably that will translate as well into an increased use in our chronic stable angina, just because pharmacy and kind of the workflow will be facilitated. So
Thank you.
we think we'll see much less Plavix, but we've not been genotyping or looking at platelet reactivity assays with rare exceptions, and the ones that I shared at the beginning of my response.
Because I asked you because we're concerned about stent thrombosis. Because in acute COVID syndrome or COVID syndrome, when we use computer care in the chip case, sometimes we worry about the computer care response.
Yeah, I don't think we should be using it anymore.
Thank you.
Thank you. And today I learned more on the 6, 8, and 12 MSA. You should achieve a minimal send area of 6, 8, and 12 for circumflex LED and left main, and we should focus on that result. Because a lot of cases we still cannot achieve the MSA of on the LED of 8 square millimeter. Sometimes we get only 4, 5 square millimeter, depends on the vessel size and Thai population. Thai population may be smaller than the US the population.
There is an alternate in terms of cross-sectional area relative to the reference. So the 12, 8, and 6 is, works, but isn't adjusted for vessel size. And so I think it becomes certainly quite important to use intracoronary imaging, get your reference diameter, proximal, distal, and the ultimate trial took reference 1, proximal, reference 2, distal, divided by 2, and gave that average for the minimal cross-sectional area. Just be careful when you are using a single stent strategy that involves left main into a branch vessel, because you will be undersizing what you accept for the left main if you include the circ or the LED distal diameter. So in that scenario, left main stands on its own, and I would state the minimal cross-sectional area should be at least 80% of left main. Does that make sense?
Yes, I agree, but I prefer to go to 85% of the EAM, the diameter for stent sizing. Because with by OCT, you can see much clearer of the external elastic membrane compared to IVUS, especially when you have calcification. The calcified segment will obliterate the imaging.
Yeah, I think that's a great point. And the one word of caution I have is start with the lesion prep, because otherwise the risk of perforation in expanding to the contralateral side increases the risk of perforation. So I think that works well when you prep and you can get reasonable symmetrical force and stent expansion across all 4 quadrants. If that quadrant of calcification, or if that 180-degree arc is not prepped and you're at the 85, 90%, and all that's being deployed in the opposite direction, that's when perforations happen. But these are big changes that we're all expected to do now.
Yeah, in your case, you start doing the left main with NC balloon, and then you follow by IVL. is that possible that IVL can create more dissection on the opposite side where the less calcified segment, or how you choose the size of the NCB for the pre-dilatation?
Yeah, that's a great question, Damras. And the equipment and the physics was designed for concentric lesions. When we do the analysis that comes out of real-world data that has been presented, it's equally safe in both. And dissections and perforations are extremely rare and are not increased when we're dealing with these eccentric stenoses. And so it works equally well in both. And that's not been observed. But we worried about that when we first started using it.
So that is the reason why you use just only 60 pounds, the energy, when you do the IVL, only 60 pounds.
A minimum of 60, because so ideally, and Coulter showed this in one of our prior presentations, it takes a minimum of 60 to create the adequate channels to then adequately expand the stent into the lesion. And so there, you do the minimum of 60. And we, early in our learning experience, you'd see the balloon yield on the IVL, and you thought you're done, but you're not done. Because when you go in and IVUS it or OCT it, you're not going to see all those little micropores. And so you've got to, by imaging, see evidence that you adequately created these little pores that then ensure that the stent can adequately expand into the lesion. And so early on, I got burned on that. I did the case, it didn't yield with the NC, then did the IVL, saw the balloon expand. I did 10 more after that, put a stent in, and then had stent regret with a very ugly deployed stent, and then had to put the IVL back into a freshly deployed stent and give all of the additional pulses, and then go back in with an NC. And the question is, what is the safety of that to the polymer and the drug? And we don't know yet.
Yeah, the case is great. And it's open to discuss. Is there any question from another attendees to ask the Professor Sigurua for the case or for any content?
Excuse me, Dr. Watan, you may ask, routinely you use the ultrasound for the puncture guide in every case or just in some case? And another question is, what kind of the hemostatic device that you use in this case after you finish the case? Thank you.
Certainly. Our preferred closure device is a per-close device, and we utilize that for all of our large bore femoral access. And we typically do two, approximately, 1030 and 130. From a radial, which are the majority of our high-risk PCI complex that do not involve impella, we do patency hemostasis with the TR band. So that's the answer to your second question. The first case, or the first question, left main PCI, always. And that was before the guideline came out. Complex coronary disease, always. ISR, always. Some type A lesions or B1, we will do some of those without IVUS, and we'll do stent boost in those cases. And then I use the term IVUS because we don't have OCT in our laboratory, but I think that one can talk about the attributes of OCT versus IVUS. I just want people to do it and to learn to interpret it and to use the data acquired to change how they approach sizing and lesion preparation.
Thank you so much, Doctor.
You are welcome. Great question.
Good morning, Professor. Thank you so much for your great case. So I would like to ask you not about this case, but according to the flavor to try about the angiographic FFR, nowadays how frequent you use it?
Yeah, that's a great question. I will tell you that in chronic coronary disease, for the assessment of moderate lesions, we do a fair amount of cath works. We do rarely wire-based IFR or FFR. The CathWorks is quite good, but it's imperfect. We had a negative CathWorks, positive IFR in a patient just a couple of weeks ago that Coulter and I did, and maybe we'll present that, at on a different day. In the ACS, I must admit, given the recent data that you point out, I rarely do IFR, FFR, or CathWorks in the STEMI, non-STEMI patient population. I think that at best there is equipoise, and in fact, some of the data points to angio.
Thank you.
And Coulter will affirm. Coulter, when is the last time I asked you to do FFR or IFR in a STEMI patient?
Never.
Yeah. So, chronic stable disease, drawing the cath
No.
works.
Yep. Yep. Trace it.
Trace it. You would have been proud. I did cath works without you, but I required Laura in the cath lab to help me.
Oh, yeah, there you go. Using your resources.
Exactly. Well, I really appreciate having the opportunity to share the case that Coulter and I did and the slides on that case that Coulter prepared for us. And then just to highlight why Damras and I care so much about imaging, but what to do with the information is just as important as acquiring the information.
Thank you very much for this very, very informative lecture and also case demonstration, and also the question and answer that we received from Dr. Sikurua. Now the time is over, 8 a.m. in Bangkok time. May I ask all the attendees to open your camera so I can take a picture from my screen. Please open camera, everyone.
And Joaquin, if you could send the
Everyone.
presentation, that'd be great.
You bet.
Yeah, the other. Please open, and then I'll take the capture the screen. You can see that a lot of our BDMS staff joining your lecture every time we have the exciting lecture from OSU. So for those who are not opening, please open before we to stop this meeting. Okay, thank you very much. Thank you again, Professor Sigurua, Justin, and Dr. Coulter. Next time we have our BHT for the strategic planning, and we'll talk about the question that Dr. Watanyu asked you for the ultrasound guided for the arterial puncture. We set up a process, the indicators for those in preparation for the coming Impella. Thank you very much, everyone. Thank you.
Thank you.
everyone. Thank you.
Bye-bye.
Great talk.
Thank
Thank you.
you.
And safe travels.
Thank you. Bye bye.
Thank you.
Thank you. Bye bye.